I would like to share with you, first of all, welcome to our country, and it's a pleasure to have you here. I would like to share with you some studies on trifocal lenses that we did recently, and these are my financial disclosure. None is relevant to this presentation. And well, we all would like to see polyfocality that which is not exist actually in nature. To see distance, intermediate, and near all at the same time. This is quite unnatural, and with diffractive optics we can achieve distance, bifocality or trifocality. And the difference is, as we all know, this is here in the intermediate. And again, as we all realize, all diffractive optics have side effects. The glare, the halo, sunburst, all of them have, as was mentioned before. The question is how much, and the question that we addressed, with trifocal lenses have more or less side effects as compared to the bifocals as we recognize them. We used all kind of trifocal lenses, mainly the fine vision Physiol, Acrylis, Zeiss, Panoptix, Alcon, but my biggest experience is the trifocal of Physiol, and this is what I'm going to talk about today. So this is what it looks like. You can hardly believe that the patients can see such a lens with so many circles, but they can see and can see very well. So we will compare the trifocal and the trifocal-toric of Physiol, the micro F and the POD FT. So this is a study of a single surgeon. We have a total of 150 eyes, 100 trifocals, and 50 eyes trifocal-toric. Mean age of the patients was a little bit less than what we see in monofocal patients. And as for the perioperative measurements, regarding the axial length, ACD, average K, and iota aberration, it was actually identical. So it's the same two groups. And here are the results. With distance correction, the distance spherical equivalent was almost emmetropia, and the average vision was 6.7.5. 90% of the patients have 6.9 or better, and more than half had this a clear 6.6 or better. All of them could actually drive without glasses. Intermediate, very similar, 96% 6.9 and better, and all of them are at least 6.12 and average 6.7.5. And the near, and this is a clear effect, was that 96% of the patients were J1 or J2. Average J1.2, meaning that almost all of them could read even the smaller letters. As for the trifocal-toric lenses, from an average of astigmatism of 1.5, postoperative was 0.3, almost emmetropia, and the results almost the same. 92% 6.9 or better, average 6.7.5. Intermediate, almost all of them 6.9 or better, and at least 87%, almost 90%, 6.7.5. And near, again, almost the same, 92% of the patients, J1 or J2, average J1.2, very, very similar. So the toric lenses did indeed correct the astigmatism. Now, we compared it to a result that we had at the same time with the Symphony toric, and I will compare only with the toric Symphony. And the results of the Symphony were, as for the distance and intermediate, almost the same, which means all of them could drive without spectacles, and 85% of patients 6.9, average 6.7.5, which was the same for the trifocals. Intermediate, again, all of them 6.12 and 85% 6.9, and again 6.7.5, but the near vision was significantly different. Less than 40% could see J1 or J2, which means that this patient cannot easily read. They can read the larger letters, but not the small letters. So indeed, this is the difference between the trifocal and the EDOF lenses, the near vision. Near vision is excellent with the trifocal, definitely not as good with the EDOF, even if you correct it recently. We look at the patients that had at least 6.6 in at least one eye, and this is about 80% of the patients, and almost 95% could see at least J1 in one eye, meaning that with both eyes open, almost 95% of them can see 6.6 and J1. So they really patients are happy in regards to their refraction. Surprisingly, patients with trifocal lenses do better in regards of the side effects. They have less glare and less halos and less sunburst as compared to bifocal. So actually they gain twice. They gain a third intermediate focus, but have less light loss or side effects. So really, probably all the light that is lost by the bifocals is concentrated on the third focus in the trifocal. So they do much better, and on top of that, this neuroadaptation further reduces the discomfort, and our results are the result of about a month and a half. So still there is time to have some improvement. Now we did another study in which we compared now 4 groups. Monofocal lenses with either trifocals, extended depth of focus, and monofocal either by a monovision or both eyes for distance. So here are the 4 groups: bilateral distance, monovision, trifocal, and EDOF. And we looked at some of the parameters. These are the lenses that you were using. For the monofocal, it was the Alcons, others Aquisoft or the IQ. For the monovision, we corrected between 1.5 to 2 diopters, so it is a real monovision, not mini mono. EDOF techniques and by trifocal fine vision. In each group, we have 50 cases. I'm sorry, for some reason it's inverted left and right, but anyway, it's 50 lenses in each of the group, similar age, and about between 25 to 40% of the patients were using toric lenses. So with premium lenses, about 1/3 we correct with toric lenses. As for spherical equivalence, the results were quite similar. In terms of the visual acuity, the distance vision was very good trifocal EDOF. For some reason, with bilateral monofocal lenses, vision was not as good as the other. Intermediate, definitely trifocal EDOF were better. And for near, only the trifocals and the monovision did good, but the EDOF, as shown in the previous study, did not do as good. But interestingly, and again, I'm sorry for the numbers here, we were looking at patient satisfaction and spectacle independence. As for distance, 96% of trifocal and EDOF did not need any glasses, whereas monofocal and monofocal distance did. Now this is interesting. How come patients with trifocal and EDOF, which are compromised, do better than patients with both eyes monofocal? And there are 2 things that I think that I can explain it. Number 1, patients with premium lenses are pre-selected, unlike patients that we are doing monofocal, which probably are older and are not as well selected. And the other thing is the workouts that we do with these patients. When we have a multifocal lens and we do refraction, at least 2 biometries, and we look at corner topography, OCT, and so on. So we use multiple formulas. So the workup of this patient is by far much better than this, in which we use just one of the biometers and just a few formulas. So probably the workup does make a difference. As for the intermediate, again, EDOF and trifocals do better than monovision, which is doing pretty well, but not monofocal or not. Near, again, trifocal do the best, and EDOF and monovision do a little bit less. Definitely monofocal aimed for distance are no good. And asking the patients, would you use spectacles at any time, any distance? So with trifocal lenses, almost just 8% of the patients would use any lenses, any glasses at any time. Whereas 1 out of 4 EDOF and 2 out of 3 with monofocal lenses in both eyes. Halos and glare can be seen as expected more with the diffractive lenses. Still, EDOF is a kind of a diffractive lens, but they do have glare and halos, but bothering, I mean really significant, only just a few percent, and not a lot of difference between trifocal and EDOFs. So just the bottom line is, do premium lenses provide premium results? The answer, I think, is yes. These lenses are really do good. And I do believe that if we do multiple measurements and we use multiple formulas and a good patient selection, then we can do extremely well using these trifocal lenses, which for me are today the lenses of choice. They are not perfect, but clinically we are very good. And until we have a real accommodative lenses, probably this is the lenses of choice. Thank you very much.